Thank you, Dr. Hussein. Now, if there is any question to Dr. Hussein, please raise your hand or write the question in our chat. Dr. Hussein will answer it. Thank you all. Dr. Hussein, first question, can you describe vessel involvement in malignancy?
Vessel involvement?
In malignancy.
Vessel involvement of malignancy. This will be the subject of the second webinar next week. I will provide many videos of pancreatic head, body, and tail masses and its relations to the important structures and the staging of this mass. So this will be the subject of the second webinar. Here in the first webinar, we describe the anatomy and the detailed anatomy of the important vessels which can change the staging of pancreatic masses, which are the important structures like celiac axis, common hepatic artery, superior mesenteric artery, and the venous confluence. So this will be the subject of the second webinar, and I will provide some videos describing the relations of malignant masses with the major vessels and the staging of these masses.
Very good. And second one, what approach would you prefer, doctor, from up to down or down to up?
I prefer always to go from down to up. Why? I start with station 1 deep to the second part of the duodenum, because at the beginning of the examination, I inflate air, distend the stomach, and go with the echo endoscope to the deep second part of the duodenum. And then I don't look at all to the I don't bother myself with the endoscopic. I just withdraw the echo endoscope. So in most cases, I prefer to do from below pole. But of course, in cases of GIST tumor, the stomach, I should inflate air in the stomach and see the mass of the stomach. But there is no rigid rules here. And some prefer to do both. Some prefer to do that and the stomach, and then after finishing, shift to the endoscopic view and go to the bulb, and then watching or seeing station 3 and then 2 and then 1, and after that they do from downwards upwards. So I do both techniques, but I prefer to go to the deep second part and then suck all air and concentrate on the sonographic picture.
Okay. Next one, we want some tips on how you handle the EOS scope in each station.
This should be only obtained by operator he is working. You are right. This will be a very nice videoing if we can do it. So in the next task, our next task is to do professional videos with a special camera concentrating on the hands of the operator and how he is doing clockwise and anti-clockwise. Here in the videos, I tried to describe this orally, but if you can recording videos with cameras concentrating on the hands of the operator, this will be very nice. And I think this is our next task, and probably within months we can start this project. It will be very nice.
Okay. Which needle gives steered in cancer and any specific brands?
And any specific?
Brands.
Brands, yes. I prefer always 22G needle, FNA. because it is very manipulative, very malleable, very easy to move, especially in the pancreatic head mass in the second part of the duodenum. Because in the second part of the duodenum, there is bending of the echo endoscope. It is not straight. It is straight in the stomach. But in the duodenum, it is bended. So 19G needle is somewhat difficult to be manipulated in the duodenum. I prefer the 22G needle and fine needle. We did here in Cairo University a study about FNA and FNB in a large number of patients, I think 300 something. And we find that there is no big difference between FNA and FNB. And the difference is the cytopathologists, professionality of the cytopathologists. When I refer my slides to someone which is professional in FNA, the results was very high. Even if with FNA, 22G needle, there are many companies. Here in Egypt, or here myself, I usually used Cook needle, FNA Ecotip needle. But if you have and it's supposed that this it's supposed that you should have immunohistochemistry, like in case of GIST tumors, like in cases of lymphoma, like in cases of neuroendocrine tumor. In neuroendocrine tumor, in many cases, you need to do synaptophysin and chromogram immunohistochemistry. And in GIST tumor, DOG1 and 117, CD117. And in lymphoma, of course, CD markers. So when you put a provisional diagnosis like lymphoma or GIST tumor or neuroendocrine tumor, you are supposed to do immunohistochemistry. So you need a tissue sample, in tissue sample. So you have in whether procure or acquire or something like that, you can do it by FNB if you are supposed to have immunohistochemistry. But in more than 90%, 80-90% of sampling of FNA of sampling, I used FNA, not FNB. Ecotip 22G needle. I think 25 is too thin to obtain enough sample, and 19G needle is too wide and traumatic and usually bloody and difficult to manipulate in the second part of the duodenum. But FNB, I think it is maybe mandatory in cases of supposed to need immunohistochemistry like GIST tumor, neuroendocrine, as I mentioned, lymphoma, and lymph nodes for lymphoma and something like that. But at the end of the the best needle is the needles you are used to do. I used to do these types of needles. Okay.
Okay. Please, for doing hepatocogastrostomy, we should localize left hepatic vein or just choose a intrahepatic branch?
When we do hepatogastrostomy, you can do it from segment 2 or segment 3. Segment 2 is just below the cardia, as I mentioned, at the level of the left hepatic vein. At the level of the left hepatic vein, you can pick up a dilated intrahepatic biliary radicle or the right or left hepatic duct. It should be more than 4 to 5 millimeter in diameter in order to target it by the 19G needle. As I mentioned before during liver examination, so it is very important to study the anatomy of the liver. Segment 2 is just below the cardia, while segment 3 is somewhat away from the cardia. So when I asked one pioneer or who created the technique, he mentioned that he told me that he do it from segment 2, except if targeting from the segment 2 be very near the cardia. So we feel that the stent will be at the cardia or the esophagus. So by then we will do it from segment 3, and segment 3 adds a fish eye appearance, as I told you. At the level of the left portal, then it is 4A and 4B, but at the ligament, at the level of the ligamentum teres, it is segment 3. So it is deeper to the cardia. So the stent will be on the stomach. So you can do it from segment 2 or segment 3. But if you intend to do it from segment 2 at the level of the left hepatic vein, you can target any dilated duct, left hepatic duct, or a big branch, and start your maneuver. But you can do it from this or that. But uh, segment 2 is more easier. It carries the risk that it is very near to the cardia, so the stent may be very near to the cardia, even crossing the cardia to the esophagus. Okay.
Okay, for diagnostic EUS exam, you do it under deep sedation or just propofol?
Propofol is a deep sedation. Propofol is a deep sedation. You mean that intubation? No, not intubation. In most of the cases, or even in all of the cases of diagnostic endoscopic ultrasound, I'll give deep sedation by intravenous propofol. But I didn't do intubation. No need for intubation. Intubation is needed for high-risk patients, generally high risk. That this is the decision of our anesthesiologist, or in case of in case of cystogastrostomy, because there will be gas in the stomach with fear of aspiration, and in cases of hepatogastrostomy or collodicoduodenostomy. But in the usual practice, I never do intubation at all. It is just intravenous propofol. And I think intravenous propofol is a deep sedation. Conscious sedation is Valium and Dormicam. But by intravenous propofol is ideal. I think it is all over the world is ideal. And some, of course, some center in Egypt and outside Egypt prefer to do even diagnostic examination by intubation and in the supine position. But here in Cairo University, you are used to work while the patient in the left lateral position and no intubation, just intravenous propofol injection or infusion.